The next talk will be how to sort out headaches by Dr. Nadie Rathnayake. Over to you, Nadie.
For that kind introduction, and thank you for National Clinical Society for inviting us to talk today. After all the interesting topics in neurology, here comes the headache. My topic for today is primary headache disorders. So what is the difference between a headache and a headache disorder? Headache, as we know, it's a single attack of pain, but headache disorders are when you experience recurrent episodes of headaches. So the primary headache disorders are the headaches when we consider about the headaches which are not caused by any sort of inflammatory infection or any sort of underlying cause. When we go to the basics, as we all know, there are no pain receptors in the brain matter. So the pain comes either intracranially or from the extracranial structures. So the things inside the skull are the blood vessels, meninges, the scalp itself, and from the skull. And the extracranial structures that would give rise to pain, which have pain receptors, are the sinuses, the eyeballs, ears, teeth, temporomandibular joint, and the blood vessels. And when we consider the cranial nerves 5, 7, 9, and 10 carry the pain pathways. So now when we talk about all the headaches, these are with regard to the primary as well as secondary headaches, is half to 3/4 of the patients, adults, have experienced a headache within last year. So it's quite a number. 1.7 to 4% of the patients have a headache at least half of a month, half of a month. And it's the 5th leading cause of emergency visits. And it's the 3rd leading cause of the emergency visits for the young females. And it's 1.3% of the patients present, the outpatient visits, the headache accounts for 1.3% of the outpatient visits, and it is the 3rd highest cause of years loss of disability. So when we consider about the primary headaches, there are 3 types of primary headaches that we are considering today. The tension type headache, the prevalence of lifetime prevalence per person is 46 to 78%. So it's the most commonest form of primary headache disorder. Migraine accounts for 14 to 16% lifetime prevalence. Cluster is around 0.1 to 0.3%. So the primary headaches are the headaches which are not caused by any anatomic, inflammatory, infectious, physiological abnormalities, and it is the most common type, accounted for about 98%, but mind you, the significant ones are the secondary headaches, where the rest of the 2% is they are very significant. And always, before considering the primary headaches, we need to exclude the secondary causes of headaches and then to concentrate on the primary headaches. So today, within next half an hour or so, I'll be discussing about 3 major types of primary headache disorders: the migraine, the tension type headache, the cluster headache, and some of the practical aspects on managing patients with headaches in Sri Lanka. So when we consider the primary headache disorders, apart from the 3 that I mentioned, the cluster headache is included in the trigeminal autonomic cephalalgia. So the cluster headache is one of the trigeminal autonomic cephalalgia, and there are other primary headache conditions, about 7, 8 primary headache conditions as well, which are not that common as of the top 3 that I mentioned here. When we consider migraine, women are more prone to get migraine, and about 25% lifetime the prevalence is there in women, and men it's around 8%. According to 2015 global burden data, it is the 3rd highest cause of disability in young females and males both. And about 70% of the migraineurs have a positive family history, though the mode of transmission is unknown. And when we consider the characterization, migraine without aura and migraine with aura are the commonest two types that we are aware of. And there are other varieties where the chronic migraine, which I'll be going later, complications of migraine, probable migraine, and episodic syndromes associated with migraine. So there are altogether 6 components of migraine headache, where these details are given by the International Headache Society guidelines. So this is the crowded slide where they categorize and they number the migraine according to the subcategories. The number 1 was given to migraine, and 1.1 being migraine without aura, and 1.2 migraine with aura. There are so many subclassifications, and 1.3 goes to the chronic migraine. 1.4 complications, 1.5 probable migraine, and 1.6 these are episodic syndromes that may be associated with migraine. So this is a quite complicated slide, but this is how the numbering is done with regard to migraine. And number 2 comes as the tension. Likewise, all the primary headaches are given a number according to their classification. So what are the diagnostic criteria to diagnose migraine without aura? The patient should experience at least 5 attacks lasting for 4 to 72 hours. So it's a fairly prolonged headache, and that is unilateral in location. The nature is pulsating. Always our patients come and say they feel the head is like it's pulsating inside, and it's moderate to severe intensity, and usually movements and physical activity exacerbates the pain. So the patient tends to stay still or lie down on a fairly dim or fairly comfortable area. And usually they are associated with the nausea or vomiting and phonophobia, photophobia. So the patients who are having migraine, they do not move around. They would be holding their head sitting on a place. So that is how they present with the migraine without aura. And how a patient with migraine with aura would present. There should be 2 attacks of headaches like this, where they feel transient visual, where the neurological symptoms like visual. They might see some fortification spectrum, they might lose their vision. So something visual, lines, halos, they should start at a point and then usually spreads out. That is the nature of visual aura. Mind you, 90% of the patients with migraine with aura, they are having the visual auras rather than the rest of the types of the auras. So the sensory auras are usually the numbness or paresthesia. When they are having this paresthesia, we call their positive symptoms, the fortification spectra, the paresthesia, we call them positive auras, whereas the numbness and visual loss, we call them negative auras. And the speech and language disability is one of the other aura, where they either get aphasic or dysarthric for a short period. And they might become paralyzed in one or side of the body, and brainstem auras are where they feel vertiginous, nauseated, and the retinal is where they get either lose the vision of one eye. And they should have they might have either one aura, or they can have successions of aura. They might start with visual aura, and then they can develop either sensory or motor symptoms as well. And with regard to the aura, at least one aura should start gradually, and it should be spreading over 5 minutes. And 2 or more symptoms can occur in succession, and each individual with aura symptom lasts for 5 to 60 minutes. Each individual aura should last 5 to 60 minutes, and at least one aura symptom should be unilateral, and unilateral, and all these conditions, the auras and the presence of aura and the headache cannot be described by any other sort of a headache according to their criteria. How the migraine attack occurs? Initially, there was the theory of vascular theory, where they said there's mainly the vascular sort of dilatation causing aura and then coming in the headache. But now it's thought it's more of a neurogenic pathology. So the hyperexcitability of the brainstem triggers release of the neurotransmitters, the 5-HT, noradrenaline. All these neurotransmitters are targeted during the treatment aspects as well. So all these neurotransmitters act on various levels to give the symptoms of migraine, either headache, the nausea, vomiting, the hypersensitivity, or the muscle spasm. All these are acting at various levels to give the symptoms of migraine. And when we consider about the phases of a migraine attack, there are three major phases. It's the pre-headache phase, the headache phase, and the post-headache phase. The pre-headache phase in migraine without aura would be the prodrome, or the premonitory, and if that is migraine with aura, it would be associated with premonitory symptoms as well as the aura. And then comes the headache, starting from a mild intensity, going up on a dumbbell-shaped curve. And once the headache is settling, it starts a postdrome, and there are symptoms associated with all these the stages as well as the durations. Of course, the durations might differ from patient to patient. So the prodrome usually starts hours or days, 1 to 2 days before the headache. And they may get the mood changes, neurological symptoms. The yawning is really common if you ask from the patients, and fatigue. Sometimes they feel bloated. Myalgias are very common, and anorexia, sometimes nausea, and even hunger, craving for some of the food is very common on prodrome. And the auras are experienced by about 15% of the patients. And I told you, out of those auras, 90% of them are visual auras, but they can have the other types of auras as well. Usually develop about 5 to 15 minutes, but it can last for an hour. And when they are associated with the specific types of auras, the classification of migraine differs. Like if they're having the motor aura, that is called a hemiplegic migraine. When they are having the retinal aura, it is called retinal migraine. And when they are having brainstem aura, that is called migraine with brainstem aura. The other, visual and the sensory, that is included in the common migraine with aura variety. The headache usually lasts more than 4 hours. But mind you, in children, it can be lasting around only half an hour. And children, of course, they can get bilateral headaches as well. Usually adults, they complain, they say the headache starts intraorbitally and it goes down, and there is some sensitivity over the cervical region going down the shoulders as well. And it's a severe, moderate or severe pain. And usually 90% of the patients are getting nausea. Some of them, they vomit, but 90% is nausea. And usually constitution symptoms are really common. They can't eat. And photophobia, phonophobia are very common. And some of the patients, though migraine is not a quite common condition to get this autonomic dysautonomia, so some flushing, tearing, conjunctival ingestion, those are called the dysautonomias. Some of the patients with migraine, they can experience this dysautonomias, and even the cutaneous allodynia, they say they can't even comb their head. They are that sensitive to the pain. And the I told you the children, their headache is less, the duration is lesser, and in children, we know adult, the females are suffering more, but in children, up until around 9 years, boys are commonly suffering from the headaches. Then by the adolescence, the females become predominant. And then about females, about 10% of the patients, they are having association with the menstruation. But the migraine associated with menstrual cycle is not included in the proper, the original the categorization of the International Headache Society guidelines. So it is included in the appendix because the mechanism there is not really clear, and that's why they have included that in the appendix. So, but there is a clear association with menstruation in females. So the post-drop can last up to 2 days. Usually patients would get episodes of depression, and they become drowsy, and sometimes they would experience cognitive changes and poor concentration. So when we consider the treatment options, we should go and start the treatment early. Then we can stop the headache being progressed into the severe form, and we should practice early intervention, and we need to give fast-acting drugs as well. And generally, the trigger, avoidance of the trigger is the mainstay. We should always talk to the patient whether they are aware of their triggers. Most of our patients, yes, they are aware. They would come and tell you these things would bring about my headache. And then we should ask them to avoid the triggers somehow, and then to start on the treatment. The two treatment approaches are the acute therapy and preventative therapy. The acute therapy, we should start the drugs which are quickly active. So the abortives are, the acute therapeutic drugs are the NSAIDs, triptans, the acetaminophen, dihydroxy, the amines. So NSAIDs usually inhibit prostaglandins. We might have to go for a fairly higher dose rather than the lower dose because they come with a severe sort of a pain. So even double dose of ibuprofen would be warranted in patients coming with acute episode, and you can use aspirin or COX-2 inhibitors as well. Triptans are one of the major the drugs that we use in acute treatment, the serotonin receptor agonists. And we need to again start early. If the patient is having a migraine with aura, it's easy for you because we can ask them to get the abortive treatment with the onset of the aura. Then the attack would get aborted. But if the patient comes without aura, we can ask with the first symptom of headache to get the abortive medication. So start early, and can be given for moderate as well as severe headaches. And when we are using triptans, of course, we might be cautious about the rebound or the medication overuse headache because it aborts the attack very quickly. So patients are really happy with the drug, and there are only few side effects. So patients tend to overuse the triptans. So using triptans more than 10 days a month can give rise to medication overuse, so rebound headaches, which we can't control because we need to completely change patients' behavior on managing medication overuse headache. So medication overuse headache is one of the complications of using triptans and the NSAIDs. Of course, NSAIDs, if they are using more than 15 days a month, yes, there is a risk of getting medication overuse headache, but is one of the secondary types of headaches. So the few preparations are there, and there are oral, intranasal, IV preparations, and we have about 4 or 5 of them in our setup, and even the government sector we have sumatriptan. And side effects wise, they can get chest tightness, jaw tightness. The jaw tightness is quite commonly reported by patients. somnolence, quite common. Now, so the contraindications to use triptans are the vascular disorders, either cerebrovascular, cardiovascular, or peripheral. And complicated migraines like the hemiplegic migraine or migraine with brainstem mora, we are not using triptans, and because of the vascular vasoconstrictor properties. And smokers and patients who are on oral contraceptive pills and patients who are having very high blood pressures, we are not using triptans. The over-the-counter medications are quite common. Even now, the Sri Lanka, they are practicing all these balms and all. It's okay if the attacks are quite less frequent. We should not tell the patients to go ahead with the pain rather than applying a balm. So if they are happy, yes, you can tell them to go. But swallowing a pain medication, the painkillers can give rise to this medication overuse. So be cautious about patients' habits when they are coming to you. So status migrainosus is like the status epilepticus. It's one of the migraine attack where they last longer. The headaches are severe and last longer, and they are refractory to conventional treatment as well. There is a place for oral methylprednisolone or the prednisolone. If the patient is vomiting, and usually these patients are vomiting vigorously, they are in severe pain, they cannot, they are really photophobic, so they are not looking at you, they are just closing their eyes and waiting. Sometimes they are vomiting, so you can give the headache cocktail, maybe double dose of NSAID, antiemetic, maybe parenteral because they are vomiting, and a triptan. Oral or intranasal preparations are there, so you can use one of those. So when we talk about, that is the acute part. So when we talk about prophylactic or preventative therapy, when we should consider a patient for prophylactic therapy. If the patient is experiencing more than 2 migraine attacks per month, yes, we should start them on prophylactic therapy. And if the attacks are long lasting, like several days per week, of course, their quality of life is affected there. So we need to give them prophylactic therapy. And if the attacks are severe, and if if they are having any sort of complicated migraines, yes, we need to complicated migraines in the sense if they are having hemiplegic migraine with brainstem mora or retinal migraine, yes, we have to consider giving them a prophylactic therapy. And when the patients are having contraindications for like the hypersensitivity for abortive therapies, yes, we have to start them on prophylactic therapy. And if the patient wishes that I should go ahead with the prophylactic therapy so that I can lead a better life, of course, we need to obey their wish. So when we are starting about prophylactic treatment, we should start low and we should go slow, not like in the acute setup where we started on high dose of rapidly acting drugs. Here we should start low and we should go slow, and we need to give them the adequate doses, and we need to try with the adequate without switching on to the other drug. We need to give them the adequate dose and adequate time to respond, and then only you are switching over to the next, or you can either bridge the 2 drugs as well. So what are the drugs that we can use? The anti-epileptics like topiramate, valproate, gabapentin, and sonizumab, and the beta blockers can be used. The most commonly used is a propranolol, but other beta blockers can be used. Calcium channel blockers wise, most commonly used in our setup is flunarizine, and verapamil is used in other countries where flunarizine is not available. The antidepressants, tricyclics, amitriptyline is quite commonly used for migraines in our setup, and fluoxetine, the SSRI. And combinations like the topiramate and beta blockers can be used, and the tricyclics and topiramate can be used. Likewise, combinations can be used. And if the patient is refractory to drug treatment, there are other modes of medications and other modes of therapies like botulinum toxin injections. So you need to give 3 monthly intervals. And most of the, I have one patient who's really happy with the botulinum toxins. Quite easy to inject in males because of short hair, but females, it's a little difficult because we have to go on injecting several sites. And other stimulation methods. And when we talk about the neurotherapy, the MABs, CGRP antagonists are coming into play now. CGRP is the calcitonin gene related peptide, one of the neurotransmitters related, released in the migraine. The second headache disorder is the tension type headache. This is the most common primary headache disorder. Because it is not that severe, the patients usually do not come to us. Migraine patients, yes, they cannot bear the pain, so they come. But these patients, though it's very common, patients do not seek medical advice. They somehow manage their headache by a balm or by ice, the physical measures, they and sometimes they tie a band around their head, which the headache would resolve. So by physical methods, they usually resolve their pain by themselves. So the lifetime prevalence is 30 to 78%, and the categorization is according to the frequency, whether it's episodic or chronic. And the frequent episodes are when they are experiencing more than 10 episodes per month. Infrequent are less than 10. Chronic is when they experience 15 headache days for 3 months over a year. So this headache usually is short-lasting, and maybe it's continuing for about 1 week. And bilateral, they are not really severe. It's just pressing or tightening type of a headache rather than a pulsating headache. It's not aggravated by the routine physical activity. So when we ask the patient whether you can do your routine work with the headache, yes, doctor, I can bear it up and I can handle my work. So that is their answer. All these patients, we need to get the frequency, and we need to give them a headache chart to mark how many attacks that they are getting per month, so that we can categorize the type of the headache and the frequency of the headache. So treatment-wise, it's physical methods, NSAIDs or triptans, again, can be used for the tension type headache. And the preventative therapy, again, the same as for migraine. The trigeminal autonomic cephalalgias are the third variety of primary headache disorder. It's a separate entity by its own means, by associated autonomic features like tearing, conjunctival injection, the facial puffiness. These features are there with the headache. Cluster headache is one of the trigeminal autonomic cephalalgia, and it is the commonest variety of trigeminal autonomic cephalalgia. The others are the paroxysmal hemicranias, SUNCT, the hemicrania continua, and probable trigeminal autonomic cephalalgia. Out of these, I'm going to discuss only about the cluster headache because it's the commonest variety. So for you to diagnose cluster headache, again, the patient should have 5 attacks of the unilateral pain lasting for 15 to 3 hours, 15 minutes to 3 hours. So it's short lasting than of migraine. Usually patients tend to, the physicians or the clinicians tend to mix up migraine and cluster headache because all these starts with the periorbital region. And the cluster headache is short lasting and usually associated with the autonomic features. And these patients, they are restless because the pain is very severe. I told you the migraine patients, they are quite, they are having photophobia, and these movements aggravate the pain. So they lie on a, they are lying still. But these patients, they are restless. So the headache is very severe in both the conditions by the patient's behavior, and by the presence of autonomic symptoms, you can differentiate between the cluster headache and the migraines when the patient presents. And of course, the clusters come in clusters. There are periods where the patient does not have headache, and then there comes a cluster of attacks. So that is how a cluster headache presents. And usually this is more common in males. It's very rare in females. So not like in migraine. The frequencies, again, the other differentiating the feature from migraine is they can get multiple episodes per day. Migraine, usually it's a single episode per day, but cluster headaches, they can get multiple episodes lasting up to 8 per day. And the cluster headache again is divided into episodic and chronic clusters. And alcohol, histamines, nitroglycerins precipitate cluster headaches. The males who are coming with cluster headaches will come usually after a bout of alcohol. Alcohol precipitates headache. Runs in families, autosomal dominant in 5% of the cases. And treatment-wise, abortive therapy is usually high-flow oxygen. These patients usually come to the hospital because they are having a very severe sort of a pain. And so you can administer high-flow oxygen or triptans, or the NSAIDs act on some of them, and bridging with the verapamil or sodium valproate, that is the prophylactic therapy. Usually they respond nicely to verapamil. And this is how the patients present with the signs. These are the other primary headache disorders, which are really not common, but are included in primary headache variety. The cough headache, exercise headache. Of course, this exercise headache, the headache associated with sexual activity and all, we need to image them to look for secondary causes as well. If the imaging is negative only, we categorize them into as primary headache disorders. So, and when we consider the practical aspects of managing patients in Sri Lanka, you know, every day you will see at least 3 patients with headaches, various sorts of headache in your life, all of you. So how to diagnose a patient with headache? It's the mainstay is history. Now, I told you how to differentiate among the primary and the secondary headaches. Secondary headaches usually are due to some underlying cause. The primary headaches are not so. And the most common variety is primary headaches, but always you need to exclude the secondary headaches to come into a diagnosis of primary headaches. So always look into red flag signs by the history. And then if you are diagnosing a primary headache disorder, try to categorize them into whether this is the migraine, tension, or the autonomic, if there are autonomic features, the trigeminal autonomic cephalalgia. So when diagnosing by the history, you might get the history which is with the features of combined headaches. They are having some features of migraine plus tension. It's usually really common for the patients to have one or more types of primary headache disorders. So you have to give both the diagnosis in your diagnostic card and give them a headache diary for you all to, it helps for you all to manage the patient, as well as it's easy for the patient to remember how many attacks they got. So headache diary is one of the major things that when you are managing a patient with headache. And examination, do the general examination and always look at the fundi. Even though you have all the features of migraine, please have a look at the fundi, because secondary headaches can present with the features of migraine, and even a patient with migraine can come later with a secondary headache. So please look at the fundi, especially when the patient comes and tell you that the headache is not responding to your conventional medication, or if the patient's headache was initially responding and then they are getting some different kind of a headache, always re-examine the patient, go back to the history, examine the fundi and document what you saw. And then when treating, use adequate doses. Do not use subtherapeutic doses, and use adequate doses. And if you want to switch to the next drug, you can switch them after giving the adequate dose of the first drug. You can combine two, but always look for comorbid conditions of the patient and then indicate why you added the second drug. And when to refer to the specialties when you are not sure about your diagnosis. Say if you have combined features, if you have doubtful findings on the fundi, please refer. And when the changing patterns of headaches are there, please refer. Then we need to look at the patient carefully to exclude a secondary headache. And if you think the patient needs some sort of imaging, yes, you can refer the patients. So when to image the primary headache disorders, mind you, secondary headache disorders always we need to imaging. So when these primary headache disorders, usually when they have a pattern change of the primary headache disorder, you need to go and image them promptly. And when the patient is not responding to your treatment, given the adequate doses, yes, you need to look for a secondary cause there. And patients who are having typical migraine, but when they are older and the onset is at an older age, yes, you need to go and image them looking for a secondary cause. And trigeminal autonomic cephalalgias, please go and image them with MRI, MRA, or MRV rather than the CT, because the vascular lesions are quite common along with the trigeminal autonomic cephalalgias. So when not to image, and this is my take-home message slide. So the patients who are newly diagnosed migraines or young tension type headache patients, you don't need to image them. Usually our patients come with a 1 week history asking for a CT. So no, you don't need to image them. And if the patient is having normal neurological examination, and the patients who are having chronic stable migraines, you do not need to examine the image. Thank you.
Thank you very much, Nadie. The short outline on primary headache disorders. Any questions? We would be happy to answer. Thank you. What would you recommend for menstrual migraine treatment?
Yes. Menstrual migraine, of course, we need to get the patient's history, whether their menstruation is regular or not. So if the menstruation is regular, the patient know the dates. So 48 hours before the episode of menstruation, the headache, we can, before the menstrual date, we can ask them to take some sort of abortive therapy, maybe NSAIDs, maybe a triptan. We can ask them to take it prior 48 hours. Then the prodrome would be settled and the headache would not come back. And then we can, if they are getting a headache, we can ask them to get abortive therapy for during the menstrual days of menstruation. And you can continue, that is that we don't need to give them prophylactic therapy unless they are associated the usual migraine plus the menstrual exacerbation.
Estrogen and progesterone acts differently as with regard to migraine.
Yes.
So estrogen probably is a non-modifiable trigger. That's why you get the menstruation associated with migraine. And progesterone during pregnancy, the migraine goes to remission.
Yes,
the physiological remission. Only physiological remission that you can pick up with regard to migraine.
Yes.
So much so that some women think, to be away from migraine to become pregnant too frequently. What is your comment about that?
Of course, it's the only physiological condition where the migraine is going into a remission.
Thank you very much.
Thank you.
Thank you for your cooperation, and we'll see you some other CME. Thank you.